So we go on to a very interesting session. I want to call at this point my panelists. If you could slowly make your way up to the stage, Dr. Michelle Butler, Dr. Benjamin Frankfort, Dr. Shivani Kamat, Amanda Eddy, and Robert Leonard. Just slowly make your way forward. We're going to have a panel session here. Please continue to submit your questions. They're going to come around and pick those questions up. You have that QR code. And so let's start with the glaucoma patient. As we get started, I just want you to give us a little bit of information about your glaucoma journey, so to speak. Your experience, the drops you're on, the surgeries you've had, just to get us started with the questioning. Who wants to start?
I can start. Can everybody hear me? My name is Amanda. I was born with glaucoma, so I'm about to be 45, so I've had it for 45 years. When I was born, I was diagnosed, I think, 3 or 4 months old, so we knew pretty quickly. I've been to glaucoma specialists my whole life. I've been using my eye drops, and I had a trabeculectomy 12 years ago, and that worked really, really well, which is great. I still use drops here and there, but I think the most important thing that I've learned over my journey is just consistency, trusting your doctor, working with your doctor, and really putting in your drops and medication. So.
Thank you. Thank you, Amanda. Do you want to add something, Robert?
Sure. I'm Rob Leonhardt, and my journey started in 2007, and through my optometrist, actually, with the puff of air, the testing that you've heard about. I had a 20 in 2007, and I came back in the same year, and it was 25. So she suggested go see an ophthalmologist, and I had to go through one because my optic nerves it's like a birth defect. They don't go back, they go back a little bit at an angle. So one didn't even want to touch me. And so I got the second one. His name's John Campagna. I wanted to give him some credit from Ophthalmology Associates in San Antonio. He's been my ophthalmologist for 17 years. He had to get me a SLT first in both eyes, 360 degrees in the right and 180 in the left. That didn't really work, so I got a trabeculectomy in that eye. That actually, it turned out I developed a tenon cyst, so that surgery in essence failed within a year. And you've heard about the tube shunt with the drainage plate. That was the next one I had in the right eye. So at that point, I was still having some fluctuating pressures, and he sent me to Glaucoma Associates of Texas with Dr. Davender Grover, who proceeded to do ECP in my right eye, which worked, and that was about 2016. It is still working today. And then my left eye started having problems, and fortunately my right eye was dominant, and I've lost probably a half to two-thirds of my vision in my right eye. My left eye is holding well, but it started getting pressures in the over 20 as well. So Dr. Grover first did GAT, and I don't know if we've talked about GAT, but it's in essence unroofing the Schlemm's canal, and it opened up the veins to right into that area, and so this episcleral venous pressure was a big issue there as well, and it failed. I moved around a little bit too much. That's something I would tell you. If you ever have a surgery, do what they say. Sit up, sleep up, and don't go anywhere after surgeries. I developed hyphema there, and so that was terrible.
Just blood in the eye.
Yep. And I'm going to end here. The last surgery I got in the left eye was a Zen. 45, I guess that's the only one so far. That has worked. That is in 2017, and that is still working right now. So, I mean, I am blessed to have had those final 2 MIGs, and I'm very stable at the moment.
That is wonderful. We're going to start taking the audience question, but I'm going to let you know, I'm going to come back to you so you can tell us the story behind your rose-colored glasses. So this next question here is for Dr. Kamat, and it actually talks about trabeculectomies, or I would say we can allude to different types of surgeries that would require a needling. So the question says, how many times after trabeculectomy can you have needling done to break up the scar tissue?
That's a great question. So, I mean, in theory, you can have as many as you may need, but your surgeon may decide. So, you know, I like to try a needling before saying that a surgery is just not working and abandoning it and doing a second surgery, especially in the trabeculectomy, like what he's also talking about, because in some people, they can work for so long. And so if it worked for a really long time, it's really worth a try to revive it and see what happens. And so say I do a needling and it works again for, you know, 5 years, 3 years, something like that, I may try it again, you know, and see if that buys more time before going on to something else. If I do a needling and it works for like a month or 2 months, or there's some kind of, you know, something that shows that the surgery is just failing quickly, then I may consider moving on to a tube shunt or a different kind of glaucoma surgery at that point. So basically, you can repeat it more than once for sure. I think for me, it just depends on how you respond.
Can I add to that?
Yes.
Is this on? Yeah? Okay. So like Dr. Kamadi said in her lecture, there's even different levels of needling. If you can, in the office, you can break up the scar tissue, but in the operating room, you can actually completely open up that surgical site and physically remove the scar tissue, give them, so all needlings are not the same. And I think you can, everyone's journey is different, and so I don't think there's not a single right answer to that, but know that there's a lot of options.
Can I add just, I've had several needlings on my bleb, and it's worked so well. Just because I'm going to live with glaucoma for so long, it was a really great step instead of going straight into another surgery, like you said. So.
That's a great point. You know, she's so young. She has had, you know, you mentioned glaucoma for 45 years, and we have many different tools in our toolkit. But when someone, traditionally speaking, when people get glaucoma, they're older. You know, they're often over 50, and when you get it in the first months of life, you just have a lot more time that we have to make these options work. And so, if in someone like her, if we can revive that same surgery and keep it working for years, that's actually a huge advantage, so that we don't have to like run out of the options in her lifetime.
And just to add slightly to that, another reason why I also prefer needling until I just don't think I can do it anymore is because the eye has limited space, right? And we can't operate in every part of the eye the same way. And trabeculectomies, if they're put in the lower part of the eye, have a very high rate of infection. So you can't use half or even maybe 2/3 of the eye for a trabeculectomy. So once you've done it, you really have to try to preserve it, because once it's gone, you may not be able to do another one.
Just the last thing on needling, I left out that I had a cataract growing in the right eye as well. I had that taken out after the trabeculectomy where the bleb was failing, and he needled the bleb during that surgery as well, trying to save it. And the tube shunt came after to help that.
Well, I hope that answers that question. So we'll be going on to the next question, and this one goes to Dr. Frankfurt. It says, what likely causes the basement membrane to normally thicken with age?
I don't like being asked questions I can't answer. But so the question restated is, you know, why does the basement membrane change with age? So I think it's multiple things. So the first is just in general, the ability of any cell to maintain its normal metabolic state worsens as you get older. And the basement membrane in the brain, for example, for aging, does something very similar. So it's not surprising that there's some kind of a inability of the system to maintain itself fully. And what I didn't really share is that it's actually even more complicated than what I showed, big surprise, which is that the blood vessels and the neurons and the supporting cells of the neurons all talk to each other, and they communicate regularly to modulate the blood vessels, the blood flow, the basement membrane composition. It's all happening all the time. So the way I'm going to figure this out is because I'm fortunate to be doing science in a time where big data is really easy to get, right? And the biggest and most incredible innovation in all of science in the last decade has really been what's called single-cell RNA sequencing, which is the ability to take an individual cell and look at all the genes in just that one cell that have been turned on or off or at a higher level or lower level than what you would expect. And by doing this in the blood vessels that produce the basement membrane in our animals, we could figure out exactly what's going on. So we've started doing those experiments. They take a while. They take a lot of smart people to figure out the math behind it. But I'm pretty confident we'll know quite a bit about that in the near future.
Thank you. So we're going to jump into a little bit more clinical stuff here. And I have a question here that says, if cataracts were removed, can you still get glaucoma? And this is up for grabs. Anybody up there?
Yes. Yes, that cataracts removal doesn't increase or decrease your risk of developing glaucoma. You're still going to have to be watched.
So which takes me to my next question. I have one here that actually talks about if you have a risk factor for glaucoma, but no official diagnosis, how often should you get your eyes checked?
I like that question. That's a really good question, and that's something that, multiple clinical trials have tried to address. I would say that if you have a risk factor that is concerning, but no evidence of glaucoma on OCT or visual field, annual visits are probably reasonable. And the only reason you might modify that is if the risk factor is really scary, like a very, very, very thin cornea or pressure that's really high but doesn't seem to be doing anything. Maybe I would do it twice a year in those situations. But in general, I think that people who have risk factors but don't have glaucoma yet, an annual follow-up is reasonable.
Well, thank you. All right. So let's segue a little bit to eye drops. There's a question here about how long can we stay on the same eye drop? Do we eventually develop resistance? And I'm sure there are multiple takes on that, so everybody will jump in on that question. But go ahead, Dr. Butler.
So there's no definite time. There are patients that are going to be able to be on the same drop probably forever and tolerate it and it be effective. And there are others who are going to be on that eye drop and they're going to develop an allergy or intolerance to that one and have to switch. Or maybe it's working but not well enough. Their glaucoma disease has progressed and you're going to have to supplement with something different. And unfortunately, we don't have a way of predicting who's going to fall into what category. So that's why we do these follow-ups. And so even, I know we just talked about the suspect, but it's hard even when you have glaucoma, how often do you need to be seen? And we try and find an interval where it's not going to be so frequently you're having to come and interrupt your life every month, but also we don't want to miss episodes where if you're having high pressure that we're having meaningful damage. And so we try and find that interval for each person, and that's going to have to be maintained over the course of your life. Even if things are stable now, we don't know what the future is going to hold yet until Dr. Frankfurt's lab figures out how we can predict everything, because that would be a game changer.
Yeah, I mean, I agree with that. I don't think it's, a lot of people get bogged down and start thinking like, oh, these drops aren't working anymore, or yeah, we're developing resistance, but really it's just your disease, really, it's worsening. And unfortunately, right now with glaucoma, we're sort of on this one-way street where we can't really reverse the damage, we can't cure the disease. We know that it progresses over time, and our job is to slow it down as much as we can and halt it at periods of time with whatever intervention we do to keep you seeing for as long as possible, hopefully the rest of your life. And so when your pressure is going up, it's often not necessarily that the drops have stopped working, it's just that your disease is progressing and we need to do something different.
I would also comment a little further about the resistance specifically to drops. That's pretty unusual for a drop to stop working biologically. You don't usually develop like a real resistance to it. There's a few exceptions, like in brimonidine, for example, where there's a cumulative allergic component. Probably one of the things that's happening is as you develop the allergy, the medicine probably will still work fine, but it doesn't get into the eye as well once it's allergic like that. In fact, allergies in general can affect the impact of drops, and it's something that's missed regularly, where if you're having an acute allergic reaction or something's going on, drops just don't get into the eye as well under those situations. So it could sometimes look like resistance, but it's really just, if you're sick or something like that. So it's really important, as been mentioned, to find that interval of follow-up, and if something looks really unexpected, to not just assume that everything has changed dramatically. Maybe it's something else going on. You should confirm before making a big change in your management.
So I'm coming back to you three. I'm going to let you know what question we're going to ask you, and it has more to do with why isn't there one course of action for everyone? Explain why each person is different. But first, I'm going to go to Robert and Amanda to tell us what is, if you have to think about the way you manage your disease, how do you manage the day-to-day sort of contending with having to deal with your glaucoma? Are there tips that you have for the audience?
The biggest thing is taking drops, at the appropriate times and levels for me, and that's because I'm still working, pretty much a 40-hour plus week, and so making sure that I get the drops in the morning, and then in the evening it's a little bit easier, but those are definitive times that I've set aside, and that's the biggest thing to me. I just heard today, or saw today, that after 6 months that half the patients don't use their medicines, and I've heard that before too. And so my biggest tip would be get the medicines and put them in your eyes. There's just no substitute for that, because the drops have held my pressures to great levels in the last 8 years.
Are your glasses one of the ways of coping with your glaucoma?
Yes, absolutely. You want me to go to the rose?
Yes.
Okay.
Yes.
So it's not just I like to see the world through rose-colored glasses. It's a little more
Nothing
than
wrong
that.
with that, though.
So I have a really good optometrist who works well with Dr. Campagna, my ophthalmologist. And, I think everybody probably suffers a little bit from glare when you have glaucoma, night glare, or even during the day and bright days. So definitely the rose color helps glare, and particularly for me in fluorescent light environments. So I think it really helps there. And also the contrast of different colors or different darkened lights it's so much better wearing these glasses. So I wore contacts for many, many years until I had some corneal problems. And I did not want to wear glasses, but it really has been good now that I've figured out through my ophthalmologist and optometrist what are the best things for my glasses.
Thank you for sharing that. Amanda, do you have something to add?
Sure. I would definitely echo just eye drops, being really consistent with that. I don't know how I put them in when I was like 15, but we made it. And then just, being really consistent with your doctor follow-ups and your visits. And also checking if for me, checking my son when he was born. So he turned 6 on Wednesday, and when he was just a few months old, I was like, we're going right now, and thank goodness he's in the clear. And we went every 3 months, then every 6 months, and now it's every 2 years. So that was really good.
May I ask a question of our patients on the panel?
Yes.
How do you remind yourselves about your drops? Do you just have it so ingrained that you know exactly when to do it, or do you have an alarm system, or what do you do to make sure you don't miss drops?
I actually have them, and I'm a veteran as well, and I know I got these during my time on active duty, but I have these pouches that are fatigue color, and I have them all in there, and literally I've done this a lot in our master bedroom. I have them there in the bedside table, doing that at night. And I'll actually take them and throw them into a chair, which is the chair I get up in the morning to do the drops. So there's nothing scientific about that, but just put them where you are, take them if you need to take them, and I have the little carrying case, and that has helped tremendously with multiple drops.
What he just told us is he has the willpower most of us lack. Because I don't know that I'll be that disciplined at bedtime. I tell people that I'm the person who gets home, and when it's bedtime, I just drop off the edge. So go ahead. You wanted to add something?
I do the same thing. They're on my nightstand. So morning and night, it's the first thing I do. It's the last thing I do before I go to sleep.
Well, so part of the reason why I ask is I feel old because I'm a little further along than these other two. In fact, Dr. Butler was a resident under my supervision when I was early in my career. And I didn't mention it during my talk. The second paper my lab ever published, the first author was Dr. Michelle Butler. So, she and I have known each other for a very, very long time. But when I was a resident, and Ron Feldman and Tosin could probably even talk about other examples. I remember we were trying to work with a local cable company to send alerts through the cable system so that you would be reminded to take your eye drops. And there was all these workarounds. There was no phones. Like I didn't have an iPhone when I started residency. There was nothing. And now we're so fortunate that we have all these tools to help patients remember to do things, and you could color code your alerts and do everything you need to do to set it all up. And I do this with my patients more often than I wish I had to, but we do it regularly to make sure everybody's remembering and what's going on. And it's just kind of funny that we were using the cable system because everybody had cable, but now nobody has cable, and you couldn't even use the system even if it worked. So it's always a challenge, and it's unfortunate that it is a challenge because the drops really do work quite well.
So the take home here is find a system that works for you. Set an alarm on your phone. I have remembered a time when I tried to set an alarm on a flip phone. That was quite an experience, but thankfully we all have phones that can help us there. Put your drop by your toothbrush, whatever it is that will help to remind you to take that eye drop. All right, so we go to that question about why isn't it the same for everyone? Why isn't there some course of action that we just go 1, 2, 3, 4 for every single person and explain why each person is different?
I mean, it's a complex answer. I think maybe we can all say something a little bit different here, but everyone's eyes are built differently. They're put together differently. Everyone's anatomy is very different. Everyone's disease process and stages are different. How quickly they progress is different. And we're lucky now that we have so many options in our toolkit that we can apply to various stages of the disease. Whereas if you think maybe, even like 20 years ago, there were really like trabeculectomy and tube shunt. Now we have this explosion of minimally invasive glaucoma surgery. And so we're lucky that we can target different stages of the disease in people and provide treatment at different stages. But I think for me, the short answer is that everyone's anatomy is really different. Not everyone's eye is going to respond the same way to different surgery types. Not everyone's eyes can even really we can't even perform certain surgeries on certain eyes. Like we can't even do minimally invasive glaucoma surgeries, for example, on people whose drainage system is scarred closed. So the anatomy plays a big role, and the severity of disease and the stage of disease that you're in and how quickly you've been progressing also plays a role. So it's very individual.
Yeah, excellent. I agree with all of that. And I think, you look around the room, we're a very diverse people. Everything about us is a little bit different, so it's not surprising that glaucoma is going to be different as well. And we are treating the eye, but we're treating the person, and people have other medical issues. They're on blood thinners. Maybe we can't do certain procedures because they have to stay on a blood thinner because of their cardiac disease. We have to get into all of those details and learn about you. What profession do you do? What kind of hobbies are you doing? Can we do a trabeculectomy, or is that putting your eye at risk for an infection, which could be devastating? So everyone has different circumstances. And if you think about it, if we had one thing that was 100% successful, we would do that for everyone. The reason we have so many different options is because it's not 100% successful, and so we keep trying. Whenever we find that one thing, then we maybe will have 1, 2, 3. But until that day, it really is a personalized, tailored approach over time that we develop.
I'll respond to the question in a slightly different perspective. So all totally great points, and we're very fortunate to be practicing glaucoma care in a time where we have so many options for the diverse needs of our patients. But one way to think about why diseases present or appear very differently across people is how much of it comes from a single gene being affected. So if you have a disease that's affected by one gene, everybody has almost exactly the same thing. So if congenital glaucoma is caused by a certain gene, you get the same look. They look a lot more similar at that stage than if it's hundreds of genes or thousands of genes, plus environment, plus age, plus this. And glaucoma in the adult phase has all these other things that bring into it. So almost by expectation, the way it appears will be quite different. And all of us have inherent responses to different medications, to healing, to scarring in general. There's medications that don't work for people, maybe because they have some genetic reason why it just will never work. But we don't know how to check those things. So as a consequence, we end up trying lots of different things and moving around, and it gives even more of an impression beyond the facts of how diverse it can be. So it's a real challenge, but I think that there's likely in the future, there'll be additional approaches that come out that help us get even better at our tailoring. We'll be able to predict a little bit better, this is the kind of person who will do well with this drop versus that drop, or this surgery versus that surgery. And then we could use that rather than kind of trying things and unfortunately failing in some cases and having to go back in a different direction.
Yeah, I'll often kind of in jest say, I wish everyone came with an owner's manual, and that would really help. But
it's interesting, that conversation. In our little workshop yesterday, we were talking about childhood glaucomas and how certain people with myocilin genes, for example, could be tentatively cured because their pathology is in the strainer, and by getting rid of their strainer, many people who have that juvenile onset type glaucoma, now that we understand both the genetics and what the treatment for it is, we found out those people do really well. So there's complexity of disease, and we're getting there. We know much more than we know 10, 15, 20, 30 years ago, and the hope is that in another 10, 15, 20, 30 years, we'll have more answers for that. So I'm going to dive into a question that kind of relates to this, but it says, when should a glaucoma patient get a second opinion? And this is open to everybody. I want the patient's perspective, and I want the doctor's perspective. It says, what should a patient then do if they get differing opinions?
I'm happy to go first. I love it when my patients get second opinions. I think it's a very important component of being a good patient and a good doctor, actually, because there are multiple ways to approach things. And if my patient and I are not seeing eye to eye about what I recommend, it's never going to be the best case scenario, right? I mean, the patient will have a different set of expectations than I do, and their perception of what worked or didn't work might be different than mine, and they may not even fully trust me because they don't know me well enough yet. And we have this in glaucoma. A lot of times, patients are seen elsewhere. They come in after problems have occurred or the disease has progressed, and surgery might be really the next step. It's hard to go and start do surgery on a patient who doesn't know you very well, right? And I think when a patient has any hesitation at all, or if I detect any sense of beyond the normal sense of concern, I encourage second opinions. And I think it's a great way to make sure that everybody is on the same page when you move forward with a big event in your life, which might be a surgery on your eye.
I totally agree with that. I think if you're even considering a second opinion, just go do it. You shouldn't have that doubt in your mind. And we're all a team. We're all here to help you, whether it's me and Dr. Frankfurt, me and Dr. Butler, me and anybody. We're all here for you and to make sure that we do what's best for you. And so I don't think there's ever anything wrong with getting a second opinion. More information is never bad. As you've seen through all these presentations, there's multiple ways to skin a cat. So there's many ways to achieve pressure lowering or control of your disease. And I think as a patient, you should go with whoever you feel the most comfortable with. And because glaucoma is a chronic disease, it's your entire life. we're all stuck with each other, whether or not we like it. And you should really go with someone that you feel like you can develop that trusting relationship with, because that's what will last for you, like for the rest of your lifetime.
For sure. Second opinions are always encouraged. And in fact, at our practice, we have the culture. If we have a complex patient, so some glaucoma is very complex, we will have a little conference and we will bring our partners in the room, and you may get 2 or 3 or 4 of us talking about you in the room, brainstorming right there, trying to come up with the best option to show that we're all kind of in this for the same end, and that's to try and get you in the best spot possible. So more brains are better.
Can I just add one more thing before? I was just thinking about, so the speaker yesterday for pediatric glaucoma was Dr. Bleeden, and Dr. Bleeden is my partner at Baylor and one of my closest friends, and she has a great saying, which she uses all the time. She says that glaucoma is a team sport. And she says that, we say that all the time. We have the same approach that Dr. Butler has here in Dallas, and you need to talk to your colleagues as a glaucoma specialist. You need to have humility and realize that not everything works, and don't be hubristic about it, and ask for help, and it works out great.
I'll take a patient perspective. What do you guys think?
I've had my current glaucoma doctor has been my doctor for 20 years, so we really do have a really good rapport. And how's your day? Oh, how's your business? And on all of that. And before that, it was a decade, and before that, Dr. Marshall Parks saw me when I was very Yes, I know.
You're
he was
dating
my
yourself now.
very first glaucoma doctor when I was just a few months
amazing.
old. So yeah, I know. I feel so lucky to have been in such great care over the years. So.
Yes, I totally agree with this. Early on, when I had the SLT, I started where I think a lot of people do with drops, latanoprost. Then over about a 5-year period, I added timolol maleate in there, and my pressures were fluctuating greatly. It was just crazy. So, Dr. Campagna is good, but he said let's find a second opinion. He actually sent me to UT Southwestern to get the academic opinion, maybe another viewpoint on just glaucoma in general. So they basically diagnosed me with glaucoma again and gave us some other things to think about. And right before the trabeculectomy that I had, because that's a major surgery, we also went to another doctor. In fact, it was one of his best friends. And he said, go ahead and do it, and so I did. But that absolutely was, and I think the king of second opinions is sending me to Glaucoma Associates of Texas to start my treatment there.
I don't think you'll ever regret it if you get a second opinion. So if it occurs to you, just go do it.
That's awesome.
And I would also say, sometimes there's a concern about getting a second opinion because the patient doesn't want to offend their doctor. I think that's ridiculous, personally. Don't ever feel that way. Like, any good doctor will not feel that way. And if they do feel that way, then maybe it's not a good fit for you anyway, and probably needed a second opinion in the first place.
I agree. So we're going to dive into a laser question. It says, who is a good candidate for laser surgery, and how many times can we repeat it? We know in light of the LIGHT trial that laser trabeculoplasty, which I like to sort of explain to my patient as using light energy to modulate, to change the way your sieve or that strainer over your drainage system works. It helps to somehow improve flow from the inside of the eye into the drainage system. And it takes a couple of weeks for that to happen. So the question is, who is a good person to get that? We have new information that I'm sure they're going to share. And how many times can you possibly do that?
So you would need to get a thorough exam to make sure that you're a candidate. If we're talking about, for example, SLT, selective laser trabeculoplasty, you do need what we call an open angle. So we need to look at your drainage system, make sure we can see the necessary structures that we need to treat so for you to have a response. I do SLT first line on my patients, actually. And she mentioned the LIGHT trial, which is a trial that came out fairly recently that compared SLT to drops. And we've found that people that get laser, their disease actually ultimately is better controlled for a variety of reasons. But one of the this is particularly an early disease, I should say. But one of the main reasons is just because what we've talked about over and over, just how hard it is to take drops. I've done an experiment on myself. I took artificial tears like 2 to 3 times a day for like 2 weeks, and it was like abysmal. Because especially if you have to take a drop in the middle of the day, and I would set an alarm. I was always in a patient room. And I was like, okay, I'm going to do it when I leave the patient room, and I never did it. I never remembered. I just went straight to the next patient. And so it's really, there's so many things that get in the way of taking your medications, even though obviously everybody wants to treat their disease. So I will offer SLT first line, certainly if, or some of the other drug delivery options actually that Dr. Butler talked about, such as Durista or Ido. So some kind of interventional process where I can take control of your disease back into my own hands. And if we're going back to SLT in terms of how many times it can be repeated, if someone has a good response, which for me, I think if they have a response for at least about a year, I will absolutely repeat it. And often I'll keep repeating it for as long as they have a response. But I would say typically that's petered off maybe around like the 4th or the 5th time. I don't know if you guys have different experiences.
Yeah, I agree with that. I think laser has been used a lot more now earlier in disease. The recent research has proven how effective it is, so we are offering it and encouraging it a lot earlier. I think it does work well in kind of mild, moderate. I do use it in more advanced disease as well, just where maybe we're trying to really avoid surgery and do whatever we can to keep the pressure down. So I don't think that it's necessarily limited, but it's maybe just not going to be quite as effective as if you were treating it earlier in the disease.
Thank you. So we're headed to sort of lunchtime. I still have some time, so I'm going to take 3 more questions. The first question is going to be for me, and it talks about how often should a visual field test be done. I'll deal with that. The next is for you, Amanda, and the question says, how did you manage pregnancy and glaucoma drops? I heard that most drops have risks. Did you stop them or tried surgery during the period of time? Then the last question is for all 3 of you, because I think it's a big question. It says, what is your most honest and detailed answer to the important question about when we will have a cure for glaucoma? So while you contemplate that, I will talk about visual fields. So visual field tests, we talked about some of that today, routinely are done once a year for most people. But there are certain instances where you have to do fields more often. If you have somebody who has disease that you believe is progressing rapidly, somebody who has central visual field loss, somebody you want to keep an eye on, you can do visual fields every 6 months, so twice a year. In clinical trials, they found out that in trying to do visual fields on patients, that you may have to repeat a field 3 times to actually get a most accurate reading on a patient's visual field, like consistent, determined progression on that patient. So visual fields are hard to do because they are so subjective. You may have a good day on a visual field and do a really good job and have a not so good day. So if I had a field that I realized that some of the test parameters are off, we get an opportunity to do one again. If it's good looking, then we do it maybe once a year. But if you're progressing really quickly and I feel we need to watch you, then you may get a visual field on more than 1 time. The technology that I talked about, being able to do a visual field at home, may be something that will be available where people can take the headset home and repeat a field sequentially because it's less stressful, the stress of coming to the office, and getting that test sent to me so we're assured that your disease is stable may be something that will be easily accessible in the future. So Amanda, I'm going to let you take your question.
Okay, great. So when we found out we were pregnant, I told my family, and then I think I told my glaucoma doctor because I knew it was going to be a challenge. I wish I remember exactly which drops we moved around, but I pretty much stayed on all my medication the whole time. And I came in a little bit more regular, not every 6 months, but it was every 3 months, just to make sure everything was okay. And I didn't have to do any. By that time, I'd already done my trabeculectomy, so my pressures were pretty normal and stable. And then once I had my son, I did stop taking my drops while I was nursing, but then went back on them. And during that period, we were just more vigilant about me coming in and checking pressure and just watching everything in the back of my eye as well. So it was manageable.
I just want to say the fact that you don't remember what drops you're taking, it's perfect, because I can never remember which drops to use in pregnancy either, and I have like this cheat sheet by my workstation when I have a patient who's pregnant. I'm like, trimester 1, what's safe, trimester 2, what's safe, trimester 3, and lactation, and then and I just see them in each of the trimesters so I can adjust their medications accordingly, and I can't remember it either, so no harm there at all.
So take home, if you realize you're pregnant or you're planning to get pregnant, it's probably good to let your glaucoma doctor know so that we can sort of make sure you're on the right set of drops. So here's that mammoth of a question that talks about when we will have a cure for glaucoma. There's also another similar question there that talks about the research that's been done for optic nerve rejuvenation. So I will just take your take on those before we round up and head to lunch.
Everybody's looking at me.
Yeah.
So it's a complicated question. So what's cure mean, right? So cure, if we break it down, we could have restoring vision. It's one part of cure. So people who've already lost vision, can we bring it back? And then another element of cure might be being able to diagnose and treat glaucoma so well that the functional loss never happens. So that's effectively a cure. You've never really lost your ability to see, to function. You maybe have some inconvenience, but functionally it's like a cure, right? That second one is much easier. I think we're going to get better and better and better at that over time, so that many people never really get to the phase where their vision is so affected that glaucoma changes their ability to do what they enjoy doing. I think we're going to get really, really good at that. The restoration part is tricky. As you may know, the optic nerve has about 1.5 million retinal ganglion cell axons. And so when you start with that many and you lose 1 million of them or 1.2 million of them, it gets a lot harder to put them back together and to make sure they go to the right place. So the challenges of curing and restoring vision is manifold. It's how do you get the ganglion cells to regrow? How do you make them rejuvenate? How do you tell other cells to turn into ganglion cells? How do you get the axons to go down the optic nerve sheath to get to the brain? And honestly, I think doing it that way is going to be very, very hard. But there are some very clever people out there who are coming up with other ways to restore vision. And I think that what's most likely to happen is that in my lifetime, and I'm 51, we will see vision restoration on its first level. And I think it'll take a little longer than that to really go from advanced glaucoma to normal young adult vision.
Yeah, I don't have an answer for the timeline. I'm optimistic, and I think it will be within my career, but I still have a lot more, hopefully many more years ahead of me. I think we're just waiting for that breakthrough, and I think once we have that breakthrough, as we've seen with a lot of other things in our lives, it's kind of exponential growth. So it could be at any point, but very hopeful.
Agree. It's very complex, and I wish we had an answer. I think there's a lot of good work being done out there with stem cells and other ways to regenerate the optic nerve. I think that's the main focus, is optic nerve regeneration. So we don't have an answer, but I think the good news is there's a lot of really smart people out there working on it, and we're all very optimistic that it will happen sooner rather than later.
So I'm always grateful for organizations that do research, like the Glaucoma Research Foundation and the Catalyst for the Cure program. I think that was brilliant, where you gather different scientists that ordinarily will work in a silo, that are working on kind of the same thing, and you put them together in a room so that you can catalyze, which is quicken us getting to that place where we find this cure that we're all hoping for. They're on the third catalyst for the cure, am I correct? And I'm hopeful. I'm hopeful that I'm a little further along in my career, but I'm hopeful that in my lifetime we will have good answers. We will see the change and the answers we're looking for in curing glaucoma, however we define it. So it's been a really, really wonderful interactive session. I thank you all for your questions. And I thank every single person, Michelle, Shivani, Ben, Amanda, and Robert, for doing such an amazing job answering all the questions.